This is episode 1 of a 6-part series archiving the core lectures from the Master in Temporomandibular Disorders and Maxillofacial Rehabilitation. To understand the most complex cases, we have to look past the mechanics of the jaw and map the underlying neural network. Across clinical practice, a significant percentage of patients present with temporomandibular joint pain and allodynia that aggressively resist classical manual therapy. You correct the movement, you treat the local tissue, and the pain persists. Professor Micheloti's clinical research demonstrates that successfully treating these specific refractory patients requires abandoning the traditional, purely mechanical focus on the joint. The pathology is driven by 3 systemic variables: persistent microtrauma, the cumulative burden of overlapping physical comorbidities, and the patient's psychosocial risk profile. The transition from a mechanical joint model toward a neurobiological pain model provides the clinical framework required to accurately diagnose and rehabilitate these refractory cases. The first step in this transition is reevaluating how trauma actually initiates the disorder, starting with an entrenched bias in dentistry and physiotherapy. There is a widespread belief, one confidently repeated even by modern AI diagnostic tools, that extracting third molars will relieve or prevent joint symptoms. The literature shows this is completely wrong. The sustained hyperextension of the jaw required during these extractions is an intrinsic macrotrauma. The prolonged stretching and pressure actively trigger the onset of temporomandibular dysfunction. This aligns with extrinsic macrotraumas. Patients who suffer cervical whiplash injuries in car accidents show a strong statistical correlation with subsequent jaw dysfunction. A sudden mechanical shock, intrinsic or extrinsic, doubles the initial risk of developing a temporomandibular disorder. Yet the initial injury alone fails to explain why the pain becomes chronic in specific patients, while others heal. Sudden impacts ignite the pathology. To understand long-term chronicity, we must investigate hidden, continuous stressors operating quietly over time. Those stressors take the form of microtrauma through continuous oral behaviors. These silent habits escalate the risk of onset by up to 17 times, making them the primary risk factor. The most critical microtrauma to monitor is awake bruxism. Clinical awake bruxism rarely involves the loud, forceful teeth grinding that many practitioners picture. It is primarily characterized by bracing and thrusting, holding the jaw in a fixed, static position with tight muscle contraction, occurring entirely without the upper and lower teeth ever making contact. Look at this comparative line chart abstracting electromyography data from a 2025 study. It measures masticatory muscle activity between healthy controls and those with chronic temporomandibular disorders. For healthy subjects, the muscle contractions are high intensity, but they occur over very short durations. The tissue contracts, then immediately rests. For patients with the disorder, the contractions are remarkably low in intensity. However, the duration is vastly prolonged. They hold the tension. This low-grade, relentless tension prevents tissue recovery. It steadily saturates the neuromuscular tolerance until the system can no longer compensate. This specific awake behavior is heavily correlated with psychological stress and active pain. Sleep bruxism, by contrast, lacks this direct, consistent correlation to daytime dysfunction. Chronic jaw pain follows the silent, relentless exhaustion of the neuromuscular system during hours of unbroken, low-level tension. Biological predispositions determine exactly who is most susceptible to that exhaustion. The OPERA study tracked healthy populations over time and recorded a steady 4% annual incidence rate of onset.
When breaking down that data, the International Association for the Study of Pain highlighted a stark gender disparity in 2024. Females are significantly more susceptible to orofacial pain than males. The first vulnerability in females is mechanical. Hormonally driven ligamentous laxity reduces structural stability, directly predisposing the joint to dysfunction. The second vulnerability is systemic. There are genetic predispositions toward chronic overlapping pain conditions, resulting in an altered, heightened response within the central nervous system. The female demographic data also frequently shows specific psychosocial traits, such as hypervigilance and kinesiophobia, which actively amplify the brain's threat perception. Gender and genetics dictate the initial biological threshold. They determine exactly how vulnerable a patient's nervous system is to the bracing and thrusting microtraumas happening throughout the day. Two patients can sustain identical articular damage, yet experience drastically different pain outcomes. George Engel's 1977 biopsychosocial model maps exactly why this happens. Patients with strong social support, emotional resilience, and good sleep quality activate a protective pathway. Their nervous system successfully prevents acute pain from chronifying. The opposite is the risk pathway. Phase 2 of the OPERA study showed that patients suffering from 5 or more chronic pain conditions exhibit hyperalgesia, a severe pain response to basic, gentle palpation of the masticatory muscles. The OPERA study categorized patients into 3 distinct phenotypes based on these variables, represented on this radar chart tracking pain sensitivity, comorbidities, and psychosocial distress. The adaptive profile scores low on all 3 axes. They process stress and pain normally. Only about 40% of the general population possesses this healthy baseline. The pain-sensitive profile maintains normal psychosocial scores, but spikes only on the physical pain sensitivity axis. The global symptoms profile fills the board, maxing out comorbidities, pain sensitivity, and severe psychological distress simultaneously. 90% of patients with chronic temporomandibular disorders fall entirely into either the pain-sensitive or global symptoms profiles. In these refractory cases, cumulative biopsychosocial stressors drive a systemic failure of pain processing that manifests as localized joint dysfunction. The ultimate consequence of overlapping microtrauma, comorbidities, and psychosocial distress is the development of nociplastic pain. Standard nociceptic pain is localized to the joint and responds to physical manipulation. Defined by the International Association for the Study of Pain, nociplastic pain is an altered central nervous system sensitization occurring completely in the absence of new tissue damage. This central sensitization creates diffuse, unpredictable pain. The intensity correlates directly with the patient's anxiety levels and sleep quality rather than the mechanical movement of their jaw. This biological reality invalidates isolated manual therapy. You cannot manipulate a highly sensitized central nervous system by pressing on a peripheral joint. Resolving these cases requires a hybrid approach. You must combine precise physical rehabilitation with deep behavioral re-education to actively disarm the patient's awake bracing habits. Mastering this level of differential diagnosis, identifying when a joint issue is actually a central nervous system issue, is the core competency for clinicians managing chronic orofacial pain. To explore advanced neurobiology and complete rehabilitation protocols, apply for the Master in Temporomandibular Disorders and Maxillofacial Rehabilitation via the link below. And stay tuned for the next 5 episodes in this series to continue expanding your clinical framework.